lecture. Continue with the virus. Okay, I just want to show where we've been and where we'll take off from. So for the viruses, we said that the infectivity will take 3 stages or 3 phases. You have the early events, the synthetic events, and then the late events. So last time that we met, we discussed the early event inhibitors. Okay, so that was already done. And then we started on the synthetic events, that is inhibitors of the synthetic events. The synthetic events you can divide into these 3 main groups: nucleotides, nucleosides, and then non-nucleosides. The nucleosides we started on, we discussed the purine analogs, and that's where we'll pick up today and finish that up. And the pharmacology of the nucleotides is very similar to your pyrimidine nucleoside analogs. So we'll take those 2 together, and then we'll go to the non-nucleosides and look at the non-nucleoside reverse transcriptase inhibitors, or NRTIs. Your NRTIs come under pyrimidine nucleosides. Okay. And then next time we'll get on the miscellaneous agent, zinc finger inhibitors, and then the integrase strand inhibitors, and phoscarnet. So that's where we are and where we're going. So to finish up the purine nucleosides, the only one we have left actually is acyclovir. That's the last one, the main one to discuss under your purines. Touched on the others. I just want to bring out some points about your ganciclovir. We've mentioned that ganciclovir is an effective agent for the management of CMV-induced retinitis, that is cytomegalovirus-induced retinitis. And these are just some brand names for your ganciclovir that you can see. If you ever come across DHPG in your reading, that's the chemical name for ganciclovir. Okay, that's your dihydroxy propoxy methyl guanine. Okay, so it's a guanine derivative, that's why we say it's a purine. Okay, so dihydroxy propoxy methyl guanine, that's DHPG. And ganciclovir, you can say acyclovir or sanivin. Okay? Both of those can be administered for systemic purposes. In other words, ganciclovir can be given pill, and it can also be given intravenously, and it can be given topically as an ophthalmic agent. This Zergan is an ophthalmic preparation of ganciclovir. Zergan is that, and you usually use 1 drop every 3 hours while the patient is awake and until the ulcer is managed. And then you go to a maintenance dosage of just 1 drop 3 times a day. And the Vitracert, you see, is an ophthalmic insertion, so it's an implant of ganciclovir. The insert would last anywhere from 5 to 8 months, so it stays there for a long time for the management of that retinitis caused by CMV. There's a drug called Vitravin. That is not ganciclovir. See, even though it sounds a little like Samulin and then we have Vitracert, Vitravin is not ganciclovir. Vitravin is one of your antisense oligonucleotides. Antisense oligonucleotides. So it's not ganciclovir. And if you see Samival, as you see there, that is Val ganciclovir. So Samival, even though it looks like Samivin, is not ganciclovir, it is Val ganciclovir. And there are some things that stand out about ganciclovir that we could also allude to. If you administer it orally, it is more for prophylaxis and maintenance. And when it is given IV, it is mainly for treatment. And the route of administration determines the route of excretion. When it's given PO, it mostly goes out through the feces. When it is given IV, it mostly goes out through the urine. And there is a ratio component to the pharmacokinetics of ganciclovir. You get lower blood concentration, or plasma concentration, if you will, in blacks and Hispanics compared to whites. So if you have to use it in a black or a Hispanic person, one will need a slightly higher dose. And in terms of its adverse effects, there's one adverse effect that stands out when you are using ganciclovir, and that's neutropenia. Neutropenia can actually be a dose-limiting toxicity of ganciclovir. Okay, so in other words, if it happens, you have to discontinue therapy with ganciclovir. And one way of managing that neutropenia is to give GM-CSF, granulocyte macrophage colony stimulating factor. Colony stimulating factor. So granulocyte macrophage colony stimulating factor. That's what you will use to neutralize that neutropenia that is caused by ganciclovir. Other than that, it can cause thrombocytopenia, and it can produce some nephrotoxicity and non-specific GI adverse effects. Okay. So, but the one that you're afraid of the most is that neutropenia that can be caused by that cyclovir. Okay, so those are some things that stand out about that drug. And now, in terms of a cyclovir, we know that it is one of your purine nucleosides. Okay. And if you look at its spectrum of activity, it works against your HSV1, HSV2, and it works also on VZV as well as your HZV. So it's effective against all of those. And it is effective against your EBV, in vivo, in the body. If it's in vitro, it works against all of those, plus your cytomegalovirus. So its effect on CMV is just in vitro. So in the body it doesn't. So you don't see a cyclovir used clinically to treat CMV infections. Even though CMV mainly causes that retinitis, it can also give you pneumonitis. So when you're talking about CMV infections, it can be retinitis, which is the one that is most often encountered, but it can also give you pneumonitis, and it can give you colitis. It can also produce gastroenteritis. So when you have a CMV infection, it's not only the eyes, it can also affect the lungs and the GI tract. Okay. And the cyclovir, like I said, is not effective in vivo against CMV, and it is also not effective against your RNA-containing viruses. As you see, all of these ones above here are DNA-containing viruses. Okay. So it's not effective against RNA-containing viruses. And it is not even effective against your adenovirus. Remember, your common cold is a member of the adenoviruses. So that's in terms of its spectrum. The mechanism of action. The mechanism of action of a cyclovir will be the mechanism of action of all the nucleosides that are used clinically. If you're using any nucleoside, the drug will be converted to its nucleotide form. Okay? And then the nucleotide form would gain some more phosphate so that you get the triphosphate moiety or metabolite. And it is that trisulfate form that will inhibit some polymerase. Okay? It's either a DNA polymerase or RNA polymerase, which will be an enzyme that is involved in the replication of the genome of the virus. Or it can terminate a growing chain of DNA or RNA. Okay, so any nucleoside that you talk about in clinical settings, that's how they would work. Okay, and of course, from your high school biology, you know you start from with a nucleobase. nucleobase differ from a nucleoside?
The base is just is without the sugar.
Exactly. So a base plus sugar is what will give you the nucleoside. And then, how does a nucleoside differ from a nucleotide?
Phosphate.
Phosphate. So if you just add a phosphate group, then it becomes a nucleotide. If you have monophosphate, you add another phosphate, it will be diphosphate. You add another phosphate, it will be triphosphate. So that's the way it goes for all your nucleosides, whether it's the one that you're using for viral infections or, as we shall see under cancer, the one that you use for cancer chemotherapy, like your 5-FU or 5'-deoxy-5-fluorouridine or 5-fluorouridine or gemcitabine and so on. Anyway, we'll talk about them later. So that's the mechanism of action of the cyclovir. It can inhibit your DNA polymerase, and then it can cause chain termination. And if we look at its ADME, we know that a cyclovir can be administered per horse, it can be given intravenously, and it can also be administered topically. Topically, you have the cream and the ointment, 5% preparation. Okay. The cream is actually not designed for genital herpes, but you see people use it, and then you find out that it is not effective. Okay. The ointment is the one that is designed for genital herpes. The ointment, the cream, is designed for oral infections like your cold sores. Okay, it's a 5% preparation also. The IV, you usually see it given at a dosage of 5 milligrams per kilogram, and that is usually given IV Q8. If the patient has HSV, that is herpes simplex virus induced encephalitis, you actually use a higher dose. It's a doubling of that dose. You give 10 milligrams IVQ 8 times 21 days. That's for herpes simplex virus induced encephalitis. Okay, the same thing that we mentioned under your IRA A. We mentioned that it can be used for that HSV-induced encephalitis. Okay, and we'll see the different dosages for your PO. Food has no effect on the pharmacokinetics of your acyclovir. Okay, Zovirax, if you will. So, food has no effect there. And if you are looking at the plasma protein binding, is about 9 to 33% in terms of plasma protein binding. With it being that low, of course, you would expect some CNS adverse effects from acyclovir because it will be able to penetrate several tissues, so you get wide distribution from that drug. It penetrates this CSF very easily. In fact, you say that the CNS concentration is about 50% of the plasma concentration. So it really gets widely distributed into the CNS and all that. The half-life of your cyclovir is about 2.5 hours. That's the The excretion is primarily through the renal system. Okay. And then you can have some fecal or feces excretion that's minor. The main one is renal. And aceclidine is one of those drugs that can also undergo excretion through the pulmonary system. So you get some of it actually coming out as expired carbon dioxide when you breathe out. Fallopy is another drug that can do that, but we'll mention it under your anti-cancer drugs. So those are the routes of excretion for the sarcomere. And then we can talk about its adverse effects before we discuss the indications. If you give a sarcomere orally, it has very, very minor side effects. In other words, the drug is very safe. You can just get things like your non-specific GI adverse effects, nausea, vomiting, diarrhea. If you give it orally, you can get some minor rash, possibly headache, possibly a small drop in blood pressure. Okay. So, drug is relatively safe when you give it orally. If you administer it IV, then it can have some renal adverse effects, that's nephrotoxicity. And how you notice that is an increase in blood urea nitrogen. So that suggests nephrotoxicity. It can also have some hepatotoxicity, and the manifestation of that is really just the increase in hepatic enzymes. So your AST, ALT, levels will go up when you administer that drug intravenously. And of course, it can produce those non-specific GI adverse effects when you give it intravenously. And like we mentioned, based on its very low plasma protein binding, it can cause a lot of CNS-related adverse effects. So you can see things like tremors, for instance, with this drug. Ataxia can be present with that agent. It can give you lethargy. Those can be related to the nervous system, hallucination, confusion, coma. So those are also manifestations of that drug. All right, so in terms of the indications for the sarcomere, so these are uses or indications. It can be used to manage Epstein-Barr virus-induced mononucleosis. Its effectiveness in that situation is debatable at best, because the best thing you do with that mononucleosis is just allow it to run its time. Over time, the immune system will take care of that, so. But, Zovirax or Cyclovir can be used if you want to actually treat, Epstein-Barr virus mononucleosis. And then, of course, you have your HSV infections, herpes simplex virus infections. If you're talking about HSV1, you can just give Cyclovir 400 milligrams twice a day for 1 or 2 days, and that can take care of the cold sore. But the one that is used more often for the HSV is the Cyclovir, in which case you can give 1 gram just once, and usually that will clear off the cold sore, or you can give that 1 gram on a BID basis for 1 or 2 days. That will also clear off the cold sore. But if we're talking about the herpes simplex virus infections of the genital type, that is what people normally call herpes, then you have different dosages that you have to use depending on whether it's an initial treatment or ongoing treatment. For the initial therapy, you will give 200 milligrams, and that will be every 4 hours. But, just 5 doses per day. And that can be used for anywhere from 5 to 10 days. Okay. And of course, we know the 200 milligram preparation of Cyclovir is the capsule. The 400 and 800 are tablets. Okay. So that would be the initial treatment of your genital herpes. Continued treatment or maintenance therapy in that situation will be 400 milligrams, and you give that BID for a minimum of 4 months. Okay. And usually the patient may need it for life. So minimum of 4 months, and at the very least you have to use it for about 10 years. But in some cases, yes, they have to take it for life to actually manage that HSV infection, genital herpes. Okay, and we know the drug can also be used to manage shingles. Can be used to manage shingles, and in that situation, you give the 800 milligrams. 800 milligrams again, 5 times a day. You do 4 hours, but 5 times, not 6 times a day for shingles, and that also you use for about 5 to 10 days. And then it can be used for chickenpox treatment. That you can use 200 to 800 milligrams, and that's on a QID basis. That's for your chickenpox. And then, of course, the one that we mentioned before, the encephalitis, the HSV, herpes simplex virus induced encephalitis. That's the one you use IV formulation. You give the IV 10 milligrams per kilogram times 21 days. That's the dosage for that. Okay. circle there. And that takes us to the end of the purine nucleosides. Okay. So we'll just say something about the nucleotides, because like I said, their pharmacology is related to the pharmacology of your pyrimidines. So the nucleotides are your adenophobia, that's one, and the other is cytophobia, and then you have tenophobia. And then you have that little group that we call antisense oligonucleotides. The antisense oligonucleotides are usually just a short string of DNA that can compete with your normal nucleotides that are used for the synthesis of your DNA. So they are your formularsine, and then you have alphavarsin. Those are the ones that are used for viral infections. And both of them are effective in the management of CMV-induced retinitis. Okay. Now, those are not the only antisense oligonucleotides that are available on the market. But the other ones are just used for something else. Let's see. For instance, we have eteplirsen, which is one of them. We have norsinarsen. Okay. And you have one that is called mepomarsen. For instance, mepomarsen is an antisense oligonucleotide that is used to manage hypercholesterolemia. Okay, so it's mainly for lipids. So we have hyperlipidemia, that's mostly due to cholesterol. You have to use mepomarsen. So it's an antisense oligonucleotide that is not an antiviral agent. It is used for lipids. Eteplirsen and norsinarsen are used for MD. So muscular dystrophy. And if the muscular dystrophy is due to a defect or a disorder in your nervous system, and that affects the spinal cord, then you use norsinarsen. So that's for spinal muscular dystrophy. If the muscular dystrophy is the kind that they call Duchenne, muscular dystrophy, then eteplirsen is the one that is preferred. Okay. And but those are not antivirals, like I said. I just gave them as examples of your antisense oligonucleotides that are used clinically. Okay. You can also see the antisense oligonucleotides used in the management of condylomata acuminata. Okay? That is your genital wart. Okay? And you know that is caused by HPV. Okay? The papilloma virus. All right, so those are your antisense oligonucleotides. You can see them used in retinitis caused by CMV, cytomegalovirus virus, or in the genital wart caused by HPV. Okay. Adefovir is an agent that was initially designed for HIV infection. But it is no longer used in that sense. So it's not shown to be very effective against that HIV. But you can see it used now in the management of hepatitis B infections. The preparation that was used for AIDS was the Previon. But if you give the dipivoxyl salt of your adefovir, that is adefovir dipivoxyl, which you will see as Hepcera, that's the brand name. And if you break it down, you see serum, and that's hepatitis. Okay, so the Hepcera preparation is the one that is used for the treatment of hepatitis B. Actually, these agents feature very well in Hep B management. If you look at some drugs that are used to treat hepatitis B, they would include this tenofovir, for instance, and that adefovir. So you see they are prominent in the management of hepatitis B. Famvir is also effective there. That is from cyclovir. You can see it used there. Entecavir, which you can see as Baraclude, okay, is also effective. Emtricitabine, I think I wrote that up here somewhere, right there. Emtricitabine, okay, is also used in managing hepatitis B. Lamivudine, that's your Epivar. Okay. Lamivudine, brand name Epivar, the one that is meant for hepatitis B, has a lower concentration than the lamivudine that you use for managing HIV. Okay, so the hepatitis B version of it, that is the drug, should not be used to treat HIV because it's too low a concentration. Interferons are also used for the management of hepatitis B. Lamivudine is also agent that can be effective in the management of your hepatitis B. So you see these nucleotides are very often used in that Hep B management. Let me say something about tenofovir as representative agent here. Tenofovir is a drug that features prominently in the management of HIV. You always see it combined with emtricitabine. And we just refer to that as your M10 combo. M referring to M-cytidine, okay? That's emtricitabine. And of course, the 10 just referring to tenofovir. So emtricitabine plus your tenofovir. And that combination is what you have in many drugs. For instance, this Truvada. Truvada is an M10 combo. And Truvada is sometimes referred to as your PrEP drug for HIV. That is pre-exposure prophylaxis. Pre-exposure prophylaxis. The tenofovir comes in two salts. The alafenamide, that's one salt of your tenofovir, and the other is disoproxil fumarate. What some people just refer to as APF, disoproxil fumarate. The alafenamide salt seems to be safer or produces less adverse effects, particularly the bones and kidneys, than the DPF salt. So what you have in Truvada is actually the DPF salt. Okay. Let's cover up this part. Okay. And you have a product that's called Descovy, which is also an M10, but instead of the DFP, it has the alafenamide salt in it, so that will be better tolerated. And you have some other very important anti-AIDS drugs that contain the M10. And so maybe you should find out what you have in Stribild or what you have in Genvoya. Those are two, Centuza. Is another combination that would have that. Victari is another one that will contain that combination. A triplet, complex would contain that M10 combination. Um, So those are very commonly used in the management of your HIV. The adverse effects that you can see from that tenofovir will be similar to what you get with all these pyrimidines and these nucleotides. Any pyrimidine nucleoside that you give for managing HIV can always give you a liver problem. And so you get hepatomegaly, the liver swells, it gets enlarged. So hepatomegaly with steatosis. That's what you see in those AIDS patients getting your pyrimidine nucleosides and these nucleotides. The steatosis just means fatty infiltration of the liver, fatty infiltration of the liver. And they also usually give you some degree of hyperlipidemia. Okay. That you see that commonly with those agents. And you can also see some hyperglycemia. It's also common with those pyrimidines and your nucleotides. So tenofovir can produce all of those. Okay. And it can also give you adverse effects on the bones, so that you see osteomalacia as being one of its adverse effects. And it can decrease your bone marrow density. So you get a decrease in bone marrow density, or bone mineral density, is the same thing we're talking about here. And can affect the renal system. It can give you Fanconi syndrome. The same thing we mentioned under your outdated or degraded tetracyclines. Okay. So you can get Fanconi syndrome, or you can just get general renal dysfunction with that drug. And then, of course, it can produce your non-specific GI side effects, nausea, vomiting, diarrhea, and can include flatulence, or gas, and then bloating. That also stems up with your tenofovir, as you can see. If you discontinue it, it can give you an exacerbation of hepatitis B infection. So, exacerbation of your hepatitis B. That Hep B elevation or exacerbation, you also see actually with this drug, ampicillin. Okay. You see with that ampicillin, and of course with your lamivudine, this drug. So lamivudine, ampicillin, and your tenofovir, if you discontinue those drugs, you can get exacerbation of your hepatitis B infections. particular drug, tenofovir. And cidofovir is just mainly used for the management of CMV retinitis. Okay, that's mainly what you use cidofovir for. There are other agents you can use for management of CMV retinitis. Apart from this cidofovir, you can use the antivirals, which we just mentioned out here. And you can use the acyclovir, you can use valve, acyclovir. There's a drug called maribuvir, which is also effective. The drug called letermovir. This letermovir, I think this is just a simple T. Letermovir stands out a little bit because of its mechanism of action. That is a drug that can inhibit an enzyme that is called DNA terminase. DNA terminase. And that enzyme actually comes like a complex, so it's called the DNA terminase complex. This is a complex that initiates that repackaging of the new viral. Okay, so in other words, it will work over here, the late phase. So it begins or it initiates the repackaging of the new viral, but it is very effective in managing, CMV retinitis. Foscarnet, we have it under your name right there. Foscarnet is also a drug that is good for CMV retinitis. Foscarnet is actually good for any herpes infection. That is any member of the herpes family. You can always use Foscarnet, be it HSV, or CMV, or EBV, or VZV, or HZV, all of them, or even HH6, that is herpes simplex virus 6 or 8. You can always use that drug. Very effective drug against any herpes virus in the body. So you can use that. Formiversin, which we talked about, your antisense oligonucleotide, is also used for CMV retinitis. Its use has actually plummeted because it was found out that your heart regimen, that is highly active antiretrovirus treatment. The heart regimen is often very helpful also in managing CMV. So that's why the use of formiversin has basically become obsolete, actually. So, one can see that. And there's a drug called lucabovir. Let's call it one of those oncoming agents or oncoming attractions, if you will. So that can also be used for CMV retinitis. That will take care of the nucleotides. And of course, the main difference there with the nucleotides will be that they will not need that initial phosphorylation. okay, because they are already nucleotides. So they already have the base, the sugar, and the phosphate. Okay. So they just need to go from the monophosphate to the diphosphate and then triphosphate to the polymerase or to get inserted into the growing chain and thereby stop the growing chain of your genome. Okay. So we can leave this up there for the time being. Now we can go to the pyrimidines, the pyrimidine nucleotides. And the pyrimidine nucleosides will include your hydroxyuridine, and then the trifluridine, that will be another agent. And your ARA-C, that's where ARA-C comes in. Arabinoside cytosine. The purine was arabinoside adenine or adenosine, but this is arabinoside cytosine. That makes it a pyrimidine. Remember, your pyrimidines are cut. Okay, cytosine, then your uracil, and then your thymine. Those are your pyrimidines. Your purines are AG, adenosine and guanosine. Okay, so that's one of them. And then you have your bromovinyl deoxyuridine. Bromovinyl deoxyuridine, and you have fluoroiodoeracitidine. Fluoroiodoeracitidine. Okay. So all of those are members of your pyrimidine nucleoside group. And then you have these ones, your dideoxy compounds, dideoxyinosine, dideoxycytosine, adenosine. With those, we can actually cross out dideoxyadenosine. I've never made it big. And dideoxycytidine has also lost favor, if you will. So out of the dideoxy compounds, only dideoxyinosine seems to still be hanging around. Okay. And then, of course, you have lamidine, which was your agent that is combined a lot with, as we shall see, with ABC, and it is also sometimes combined with anthracycline in some cases, or tenofovir. Then stavudine has also lost favor. It had a bright prospect when it first came on the market, but not so much today. So the primary agent among the pyrimidine nucleosides is azidothymidine, which is that AZT, azidothymidine. And that's the one that we will take as a representative agent for your pyrimidine nucleosides. ABC, which is abacavir, let's call it ABC. Abacavir is always used in combination with lamivudine. So you see this too being used in combo a lot. One thing that stands out about ABC is hypersensitivity reactions. That can actually lead to the discontinuation of that drug, to use it. Is that hypersensitivity reaction that it produces. You also get a lot of hyperlipidemia with your ABC, and of course the liver issue, that is hepatomegaly with steatosis. You can also get it with ABC, but that hypersensitivity reaction is usually very serious. It can even lead to death, with that drug. And that's why you want to do some HIV testing before you use abacavir. But anyway, it's a commonly used drug today, but always in combination with lamivudine, and then you have ampicillin. So the main one we'll discuss is azidotamidine, which of course is your AZT. That's the representative agent for periods. Hydroxyuridine, mainly used for eye infections. The same thing with your trifluridine. If you have conjunctivitis or keratoconjunctivitis caused by, say, any member of your herpes family, you can see those two agents used. Trifluridine is actually less or better tolerated, so because it's less adverse effects than your Stoxil or hydroxyuridine. Arabinocytosine is a drug that you can use for chickenpox, you can use it for shingles, and you can use it for HSV infections, be it oral or genital, and it is also useful in cancer. Okay, we mentioned Burkitt's lymphoma. Okay, Burkitt's lymphoma that can be caused by EBV, Epstein-Barr virus. Okay, a very prominent drug in the management, in the regimen that is used for Burkitt's lymphoma is that RC. And not only that, it can be used for acute leukemias, like your acute lymphocytic leukemia. Acute lymphocytic leukemia can be used for acute granulocytic leukemia. And occasionally you can see it used in CML, chronic myelogenous leukemia. Okay, chronic myelogenous. Chronic myelogenous leukemia. So that drug is more used today in cancer than it is used in viral infections. So that's your RC. And by the way, those hydroxyuridine and trifluridine, they're mainly used topically in the eye, but they do have an IV formulation, both of them, particularly that hydroxyuridine, and the IV has several adverse effects that are related to the CNS, but anyway, they're seldom used today, not often. BVD, bromovinyl deoxyuridine. BVD has now been approved, well, it's been approved for some time now, at least for 4 years. You can give it orally. It's available as an oral preparation. And it has a peculiar mechanism of action. It can inhibit what is called APEX1. That is an enzyme system that normally repairs DNA. Because we're constantly having damage to our DNA. Okay, but when the DNA is damaged, we also have enzymes that are involved in repairing the DNA. Okay, and one of those is that enzyme that is FX1, and that facilitates DNA repairs. So if you gave bromovinyl deoxyuridine, then it can inhibit that FX1, so you don't get DNA repairs. And if you don't get DNA repairs, you get apoptosis. So you get programmed cell death in that virus. And the use of bromovinyl deoxyuridine is mainly used for shingles. So we have an orally administered drug that is very effective in the management of shingles. It's about 125 milligrams POPD that you use for shingles management. Okay. And psilocybin, which is fluoroiodoeracetidine, because cytidine, so it means it's a pyrimidine nucleoside, and then it follows the same or the usual mechanism of action, which is to inhibit the polymerase and then cause chain termination. That drug is at best questionable. Okay. So it's not a drug that we should be concerned about right now. But just know that it is out there. It is available for one wants to go through the federal government to get it and use it. But it's not something we need to discuss here. And so we can do AZT as a representative of your pyramids. If we look at the spectrum for your AZT, AZT can be looked upon as an antiviral drug, an antibacterial drug, and an antiprotozoal drug. Okay. So, in terms of its antiviral spectrum, it is effective against HIV, because HIV-1, and it's effective against HTLV, HTLV-1, human T-cell leukemic virus. So it's effective against that. And I used to mention that it's effective against HTLV-3, but that was before HIV was even discovered. Because back in the day, people thought that AIDS was caused by HTLV-3. If you look at the symptoms and the mode of infection of your HTLV-3, very similar to what you see with HIV-1. So I don't put that in there anymore because we now know that it's HIV-1 that actually causes AIDS. So it's effective there. It is also effective against Giardia lamblia. that is a protozoan. That's a protozoan that causes a lot of GI symptoms. The disease that it produces can be named after its first name or its last name, that is after the genus or the species. So you say that it produces giardiasis or it produces lambliasis. So those are diseases that you get from that Giardia lamblia. ACT is very effective there. That's why you say it can be an antiprotozoan or antiprotozoal agent. And it's also effective against your enterobacteriaceae. Okay. That is your gram-negative aerobic bacilli, most of the ones that are enteric. So when you see it's antibacterial, it is less effective, even though it's a little bit effective, but it's less effective against HIV-2. HIV-2 does not cause AIDS. Okay. HIV-2 would also give you lymphadenopathy, just like HIV-1. But it doesn't produce that full-fledged AIDS that you get. HIV-2 never becomes HIV-1. That was one of the points that we made in that paper way back in 1990. And this was what you found in West Africa, HIV-2. So it doesn't cause AIDS. But if you look at Central Africa and Southern Africa, including South Africa itself, it was mostly HIV-1. And it just seemed like people that got HIV-2 could not contract HIV-1. So the suggestion in that paper that we made was that HIV-2 was probably made as a specific antidote to HIV-1. But there's a whole lot more behind that. But AZT is effective against your HIV-2, but not to the extent that it affects your HIV-1. And it's not commonly used for DNA-containing virus infections. It's mainly your DNA-containing viruses. So that would be the spectrum. In terms of the mechanism of action is the nucleoside. So it can inhibit DNA polymerase after conversion to its triphosphate form, and then it can inhibit or it can cause chain termination. And because of that 3-azido substitution, it's actually 3' azido substitution, because the polymerase cannot read it beyond that point, and so you get chain termination. So those are the mechanisms by which your AZT works. For its admin, the drug can be given pill, and it can also be administered intravenously. Can also be administered intravenously. Food tends to decrease its bioavailability, especially fatty food tends to decrease its bioavailability. The F factor there is just somewhere around 60%. So in other words, you have to do a different calculation if you're moving the patient from IV to PO. Okay. The half-life of the drug is just about 1 hour, and the plasma protein binding is about 25%. Again, low ppb, which means CSF and then CNS adverse effects. And in terms of its metabolism, it is metabolized by your glucuronide transferase. And that is a point of drug-to-drug interactions with your AZT. Drugs that inhibit this glucuronide transferase will tend to cause an accumulation of your AZT and hence the toxicity of AZT. So if you administer AZT concurrently with, let's say, probenecid or aspirin, all of those, can inhibit this enzyme and give you more of the hematologic adverse effects of your AZT. Because AZT can cause granular cytopenia, it can cause bone marrow depression, so you get anemia. All of those will be elevated or enhanced if you give AZT concurrently with an inhibitor of that enzyme. And the product is just generally referred to as GAZT. Okay. And that's your glucopyron uranosil. AZT. So the G that you see here, that's what it stands for. The glucopyron uranosil AZT. And that GAZT is actually not active in terms of antiviral activities, but it may contribute to the adverse effects of your AZT. The excretion, the excretion is primarily renal for your GAZT, and some of it will go out through the feces, but the primary one is urinary. It can undergo both GF, glomerular filtration, as well as tubular secretion when you give that drug. So that's the ADMA for that drug. And the indications, the indications can be, of course, prophylaxis of HIV infections, and of course, it can be used for treatment. It can be used for treatment either alone or in combination with other agents. We always mention lazy. That's lamivudine plus zidovudine. Zidovudine is the generic name for AZT. So we say it can be used there, and that's your combivir. Combivir. And you can add ABC to lazy, and that will be your trizovir. So trazodone, that is 3, will be lamivudine, zidovudine, and ABC or abacavir. That will be that. So that's a combination that you can see used in AIDS. Okay, so the adverse effects of AZT. One is that granulocytopenia. Granulocytopenia. Okay. And that can be seen within 6 weeks of initiating therapy with zidovudine. Okay. And of course, you can use that GM-CSF that we mentioned under your ganciclovir. You can use it in the management of granulocytopenia. Then you have anemia, which you can also see within 6 to 8 weeks of initiation of therapy with AZT. And this is a it's a macrocytic form of anemia that you get with your AZT. And then the effect on muscle. You can get myositis with that drug. You can get myopathy with that agent. Myositis, of course, you're just talking about inflammation of the muscles, and that can lead to degradation of the muscles. Myopathy would be things like lethargy, like muscle weakness, like paresthesias within the muscles, like arthralgia and myalgia. So all of those will come under your myopathy that it can produce. And the drug can also produce the ones that we've mentioned for your pyrimidine nucleosides, that is hepatomegaly with steatosis. So you can see that with the drug. And we also said you can get hyperlipidemia with all these agents, as well as hyperglycemia. So AZT can produce all of those. On the GI tract, it can give you the non-specific ones, the MDD, but you can also see a swelling of the tongue during therapy with AZT, and of course that will make swallowing difficult and painful. Okay, so possible dysphagia may be seen with this agent. So it can produce all of those ones. And then of course it can have an effect on the nervous system. So you can see seizures, for instance. That's probably the adverse effect that you would notice early on during therapy with AZT. It seems to occur within the first 48 hours of administering your AZT. So that can be seen. You have insomnia that can also be present there. Headaches, and the headaches here are not just regular, they are pounding, severe headaches that one gets with that AZT. And you have Wernicke's syndrome that you can get with AZT. Normally, you get Wernicke's syndrome in alcoholics because it stems from a decrease in the ingestion of vitamin D, particularly the vitamin B1 timing. You know, the alcoholic guy is not concerned about nutrition. The alcoholic guy is not concerned about ingesting B vitamins. The only thing he's concerned about is the bottle. And that's why they have low levels of thiamine. And if that if that continues over an extended period of time, then you get Wernicke's syndrome. The temperature of the body will go down, so you get hypothermia. The patient will have ataxia, convulsion, confusions, coma, all of those, and even seizures. So the seizures can be part of the Wernicke's syndrome, but you know they're different because the original AZT-induced seizures occurs within the first 48 hours. Wernicke's syndrome does not show up until 6 to 8 months into therapy with AZT. So those are CNS related adverse effects there. And then you have hyperpigmentation with this drug. Hyperpigmentation. Usually you have a bluish discoloration of the skin and the nails, both toenails and fingernails. And that is seen more in blacks, or it's more pronounced, let's put it that way. It's more pronounced in blacks than in whites. You can also see that hyperpigmentation, especially in children who are being treated with that other pyrimidine nucleoside, anthracycline. Okay, let's see, that drug right there. So, anthracycline is your pyrimidine nucleoside that can produce this same adverse effect that you see with AZT. But anthracycline seems to produce that more in children than in adults. The children will complain of palm sweating, and then you see the discoloration in those children. Okay. So those are the adverse effects. There are drugs you can actually use to manage some of these adverse effects of AZT. The lipodystrophy that it can produce, just like they have lipodystrophy that we mentioned under insulin. That was last semester. You can get lipodystrophy with AZT. You can manage that with, different sites, changing the sites of administration, if you will. And you can manage there's a drug called Filizat. You can use that drug to manage the torrential diarrhea that the patient experiences when they're taking AZT. There's a drug called Tura, which you can use to manage a form of the lipodystrophy that you get with AZT. So there are drugs that one can use, and for Wernicke syndrome, of course, you just replenish vitamin B1. You give 100 milligrams of vitamin B1. Usually you want to administer parenterally in that situation to reverse Wernicke's syndrome. And then for the seizures, you use your regular drugs like gabapentin, for instance, and sometimes they use Lyrica to actually manage that. Vampart is another drug that you can use to manage the seizures that are associated with AZT administration. Okay. So, okay. So we have some of these. Here are some other ones that you should know the combination of the components of. That's one called Synphy and Synphy-Low. You have Delgaster. You should know, let's see. We'll be coming around to all of this. We mentioned Vato is another one that is very often used today. The Nova, and we'll hold the rest until we get to your guest fees, another one we should mention. Guest fee. Okay, so in 5 minutes, let's run this off. And just go to the non-nukes and start with your NNRTIs. The NNRTIs would include drugs like Belaverdin, that's one, and one is Antivirals. So 1, 2, and 3. Nevirapine, one of the earliest NNRTI. Mention driving, Ripivirine, and viral. is Caldora. Wiring. Then Antivirals. So the one that we will take as the representative agent will be your provider. Out of your NNRTIs today, Echovirin and Ripivirin are the two that are most often used clinically. Some common things that we can say about the NNRTIs. Number one, they all have a very high plasma protein binding capacity. Okay. The only possible exception to that rule is nevirapine. Okay. Nevirapine. Number two, they all have, a very high plasma protein binding. Okay, so long half-life, high plasma protein binding, common to all of them. In terms of the half-life, this one is also low variety. Then they all get excreted through the fecal system. So they're different in that sense from your pyrimidine nucleosides. So the NNRTIs get excreted mostly through through the fecal system. And of course the mechanism of action is the same. They give you a non-competitive inhibition of the reverse transcriptase. Okay. So all of those are common to them, and we can quickly do equivalence. Well, let me mention one other common factor. It's what we call auto stimulation or auto induction. In other words, they can induce their own metabolism. Basically by stimulating, the enzyme that is responsible for their metabolism. For instance, if the substrates for 3A4, they can also stimulate 3A4. So you get what you call auto-induction with your NNRTIs. Ripivirin is a little different here. Ripivirin does not stimulate and it does not inhibit the enzyme system that metabolizes it. It is a substrate for 3A4, but it does not stimulate and it does not inhibit 3A4. Okay, as opposed to Antivirals, which is the one that we'll discuss mainly. And I think we can do that in just 2 minutes. So Antivirals, if we look at its mechanism of action, okay, it will simply be that. Non-competitive inhibition of the reverse transcriptase. Non-competitive inhibition of your reverse transcriptase. And we look at its ADME. Equivalence is administered orally. It comes in 50, 100, and 200 milligram strength. So you give it 3 times 200. QHS, as opposed to your ribavirin, which you just that 25 milligrams POQD. So they're different in that sense. Okay. And in terms of food, food can increase the AUC of your efavirenz. Okay. And the half-life is about 40 to 55 hours. So very long. With your ribavirin, the half-life is about 50 hours. So it's within the same range in terms of the half-life. And then you look at the plasma protein binding for your efavirenz is about 99.5% plasma protein binding, you know. And for ribavirin, it is like 99.7% plasma protein bound. So about the same level there. And excretion, like we said, is primarily fecal, and that's the same for your ribavirin. So renal dysfunction does not affect the pharmacokinetics of your NNRTIs. Okay. Indications for efavirenz. The indication, of course, will be HIV. That is HIV/AIDS management. Usually used in combination with other agents. You can use efavirenz in combination with M10. Okay, and that is one that was mentioned before. You can also use that ribavirin with M10. Okay, Atripla with the efavirenz with M10, Complera with the M10 plus ribavirin. So they're used in combination. You always want to use an NRTI in combination with other agents because resistance develops rapidly to your NRTIs. So that's why you always want to use them in combo. Adverse effects that you see with efavirenz. Number one is related to the CNS. So even though it is extremely highly plasma protein bound, it produces a lot of CNS adverse effects. That suggests that there is an active transport mechanism for its penetration of the CSF. Okay, so because it's highly plasma protein bound, you shouldn't have seen a lot of CNS, but CNS is number one in terms of the adverse effects of that drug. And that's why you give it at bedtime, because the drug can produce nightmares, can produce what some people describe as bad dreams. Okay. That's one of its side effects. And it seems to cause both sides of your CNS adverse effects. It can give you insomnia, and yet it can give you somnolence. It can give you depression, and yet it can give you euphoria. This depression is a therapy limiting adverse effect of that drug because it can lead to suicidal ideation or suicidal attempts. Okay, so that's one thing that one would always have to watch out for in terms of using that drug. So that's one. Then adverse effects on the skin. That is also something that's prominent among your MNRTIs, skin-related adverse effects. Rash, your urticaria or hives, and then SJS, Stevens-Johnson syndrome. It can be bad enough to even warrant discontinuation of your MNRTIs, in this case, Antivirals. So it can produce those, and you can have pancreatitis with this drug, and it can produce xerostomia, dry mouth. Okay. Occasionally, can produce your MVD, nausea, vomiting, and diarrhea. Okay. The liver can be affected. Basically, all you see will be the elevation of hepatic enzymes. So you can see that in this agent. And sometimes, minor though, it can cause some serious cardiovascular related adverse effects like tachycardia, like flushing. Those two have been reported with this agent. And then lastly, cholesterol. It can give you an elevation of cholesterol, so hyperlipidemia, but particularly the cholesterol can be elevated with this agent. Okay, we'll hold it there. We'll start off next time by comparing the drug-to-drug interactions with your AZ3 and with your Antivirals. Questions?
So, there was a list you gave of M10, and then later by their side you put down SIM5 and SIM5 low. Are those also M10s?
Mm-mm. That's what you should find out. Okay, but just to give you an idea there, those have to do with lamivudine. Yes.
For aciclovir, do we, is it
For which one?
aciclovir?
Okay. Yeah, I got it.
You were mentioning the CMV, the types, the retinitis, pneumonitis, but for this, is it just for retinitis or the rest you mentioned?
No, I just gave you what CMV can cause. Okay. If we mentioned the drug on the retinitis, then it's just for that. Yeah, but CMV can also produce your pneumonitis and gastroenteritis and colitis. Ganciclovir and valganciclovir, for instance, are very good for retinitis, but they can also be used in those CMV-induced infections. And when you check out those M10 combos, try to know which ones contain which tenofovir salt. In other words, is it alafenamide or the DFP in there? Okay. Any other questions? Okay, we'll see you around.